Okay, so I guess we can start. Welcome to the Diabetes and Obesity Collaborative Lecture Series. Please sign the attendance sheet, and the online people, please check the chat messages for we might request some information. Today's presentation is Effect of Health Information Technology on Cardiovascular Disease Risk Management among patients with diabetes, presented by Dr. Yilin, Yoshida, and Dr. Eduardo Simoes. So I have the honor to introduce both speakers. Dr. Yoshida is a research assistant professor in HMI. She received a PhD from LSU, Louisiana State University in Public Health, and MPH from Tulane. And her research is related to chronic disease prevention and control, specifically diabetes, obesity, and cancer. Dr. Simoes is our chairman. He's a Dr. Stuart Westbury professor, and he's leading he's co-director of the CDTR grant. He's a physician and a public health researcher with multiple research interests spanning diabetes prevention, information technology, in public health interventions, and for obesity and diabetes. With that, we turn it to Dr. Yoshida.
Yeah. So today, I'll be talking most of the time. My boss will add something if I, missed out some important things for this study. So thanks everyone for coming, and I'm so happy because this is the end of the week, and I see the crowd. So thank you so much, including folks from basic science and from clinic and from biostatistics. The background, that's awesome. Thank you for the support. So so today we are going to present you a paper that we completed last year and recently got accepted for publication. So the topic is the effect of health information technologies on cardiovascular risk factors among patients with diabetes. So CVD is a major cause of morbidity and mortality for individuals with diabetes. And for folks, yeah, so this is slides. So for individuals who have diabetes, they have more than twofold higher risk to develop a form of heart disease. And they are also 2 to 4 times more likely to die from a heart disease compared to folks without diabetes. And this graph shows some statistics and also indicates the importance of managing CVD risks in this patient group. However, evidence have shown challenges. So patients with diabetes, they face very complex treatment regimens, including medications, administration, and the lifestyle changes, and also the risk monitoring. So one study found that less than half of the patients with diabetes who regularly visit their care provider meet the recommended level for blood pressure and lipids. So if the traditional care and treatment cannot meet the needs for patients to manage their disease and risk, then innovative approaches should be developed, tested, and implemented. So increasingly, data has shown the important role of health information technologies, HIT in short, its important role in chronic disease management. So HIT can support provider decision-making through electronic risk assessment, alerts, guidelines, and prescribing. It also can facilitate patients' self-management through risk communication, web portals, telemedicine, emailing, and secure messaging. So in the past 2 years, we completed 2 systematic reviews and meta-analysis to examine the effect of health information technologies on diabetes management. So I believe Dr. Simoes presented our first paper, which we looked at the HbA1c reduction. And because CVD is a major cause of death for patients with diabetes, especially for type 2 diabetes patients. So the second paper we focused on 6 primary CVD risk factors, including systolic blood pressure, diastolic blood pressure, high density lipoprotein, the good cholesterol, and low density lipoprotein, the bad cholesterol, triglycerides, and weight. And here I want to show you the article screening process. So we focus on peer-reviewed randomized control trial that published through end of 2017. So we searched multiple databases, including Medline and the Cumulative Index of Nursing and Allied Health Literature and Cochrane Library for eligible articles. We also did the supplementary searches using the reference list that we identified from our literature search. And we did the title screening and abstract screening. We read the full test articles, and we excluding some eligible studies. And at the end, we have a total of 27 studies that included in our analysis. And this 27 contains one or more CVD risk measurements. And we have most of studies having the blood pressure measurement. We have the least number of studies have the weight measurement. So this slides will show you the summary of the characteristics of included trials. We have a total of 3,290 participants in our analysis. We have the studies across all over the world, 6 from the US, 9 from European countries, and 6 from South Korea, and 1 from Canada, 2 from China, 1 Iran, 1 India, and 1 Japan. We have the mean age range from 45 to 76 years old. And this older groups is really the key demographic target for lifestyle interventions. So 23 studies, majority of studies, had even gender distribution. We have 3 studies only focus on men, and 1 had no gender information. We have 20 studies using mobile phone-based interventions, and 7 had hybrid interventions, so primarily using mobile phone-based intervention plus some kind of technology components. We have 3 trials using web-based intervention, and 4 using text and short messaging, and 1 using video talk. We have 10 studies using a combination of medical care providers deliver the intervention, and 4 exclusively using nurses, and 1 using physician to deliver the intervention, and 4 using a combination of personnel, including people with non-medical background, while A study has no information on the makeup of intervention personnel. The intervention periods range from 6 weeks to 1 year, with a median length of 6 months. So from this slides, we're gonna present you the meta-analysis results for our outcomes one by one. And first look at the blood pressure, the SBP.
Dr. Yoshida,
Yes.
could you say just a few words? I know we skipped on the analytical methods, what software you use, what kind of a test we use, so when they
Sure. Yes, so we use a software. We didn't use R. I know you guys said this R probably can do a better job and it's more complex. So I just use a comprehensive meta-analysis. So this is the package that is readily available for researchers. And basically, I just input all those parameters that I found from individual trials into the software, and they can do the magic behind the scene. And I use a random, not fixed model, but random model for the meta-analysis, because fixed model is too idealistic, I think, because normally if you have a meta-analysis, you have different studies focus on different populations. You wouldn't meet the assumption that each study would produce a identical impact or effect. So that's assumption for fixed model. So I think normally people would choose random model for meta-analysis like this.
And the metrics we use in the meta-analysis are adjusted.
Oh yes, I'm going to mention about this in the results. Yes, Dr. Simoes. So we have the differences in means. So lots of people call this raw differences in mean, but it's actually not a raw. So it's weighted in the meta-analysis. So this raw is really, relatively speaking, to the standardized mean differences, which we also added at the bottom of the slides is Hedges G. So back to the results for SBP. So we have 22 estimates for this SBP measurements in the trials here, but only a few, I think only 3 studies, they had a statistically significant reduction of SBP due to the use of HIT. But collectively, if you look at the forest plots on the right, we see the effects of most of studies actually lean towards to the intervention size. So meaning it favors intervention over the controls. And if you focus on the diamonds at the bottom of this, the graph, so this is a sort of the summary measures for the differences in means. So collectively, the use of HIT is associated with reduction of SBP by almost 4.8 millimeter of mercury. So Hedges G, so this is standardized mean differences. And it's also frequently called effect size in social science. So especially in the context of meta-analysis. So there are some benchmarks for this value. So 0.2 indicates a small effect size, and 0.4 is a medium effect size, and 0.8 is a big effect size. So from this value here, you will get a sense of how big of the size effect that is generated from the HIT intervention. So it's close to medium.
So did you also do some homogeneity test for the?
Yes, I did. Actually, it's included in the supplementary slide. It's not here, but at the very end, I can present it to you later. Yes, good question. Definitely.
But
by statistics.
sure, if I may comment,
Yeah.
you can see meta-analysis does its job when you see that look at the diamond model. The diamond model tell what the average estimator is. And
Yeah.
more importantly, the confidence interval is very tight because you have
Yes.
average across all multiple tests, increasing the population sample size artificial. That's what the meta-analysis does.
Yes.
So it's doing its purpose. And the main reason, just to remind you what a meta-analysis is supposed to create, is supposed to find association that are being hidden by lack of power. Many of these studies actually do have lack of power. And that's an important concept in meta-analysis. Therefore, when you pull them together in one, it's like one big study, you can see the effect is actually significant statistically, and more importantly, significant clinically. Nearly a 5 million reduction for an average of 6 months. It may be significant clinically too. So it's a medium effect size. It's not a huge effect size, but it's nonetheless important. Very important.
Yeah, so this diamonds is really just like Dr. Simoes just said, it's effects from all the trials combined and average. So this is sort of telling you that the common effects or the summary effects of all the trials that we can identify. So next one is for the DBP. So again, we found a statistical significant effect, the common effects. The differences in means is minus 2.2 millimeter of mercury. And the Hedges G, again, is 0.3. So it's close to the median, in the middle of small and medium. So this is a results for HDL, so for the good cholesterol. So we were hoping to see that HIT can improve the HDL. And our results was in line with our hypothesis that the use of HIT interventions was associated with almost 3.8 milligram per deciliter increase in HDL. And this is the result for LDL, the bad cholesterol. So Yes, we found a very significant results, the common effect, the diamond. If you see that the use of HIT was associated with 8.1 decrease in LDL.
So did I miss something? Did they adjust this one for age, or is it age adjusted, or?
The HG is a standardized measure that's adjusted for features of the designs, including the population main characteristics. So whatever parameter the software asked her to do, I can't remember age or gender or something. Some of the study did not have one or two did not have clear gender. So you missed that out. But so the characteristics are kind of incorporated, but it's not like we do a direct adjustment or regression. This is different. This is a random across all the studies using the average parameter as a measure.
Yeah, because I guess I was thinking the HSD might adjust, like if you have a metric, it might be measured like in units. But
HG is asked and adjusted. It adjusted all these factors.
Okay.
So this software, have you used this software? So this software, it actually uses for like age or like the baseline measures. You have to actually conduct meta regressions like separately to look at like the effect.
Yeah,
It does not, yeah.
That was I guess
Yes,
maybe
that's
Yeah.
that's a good point. We didn't do the meta regression.
Yeah.
But it'll be very specific. What it does is that when you look at the theory, it said it accommodates all these differences to the random effect. Because they are expecting them to be different in regard to age. Each study group, the age distribution cannot be. They don't assume, bottom line, the random effect is a very conservative. It assumes that the age group will be different, the gender will be different, the basic thing that could affect the outcome, and more important, the characteristics of the design.
So we didn't do the meta regression. So this is the thing. I think I more want to apply this if we are not doing the evaluation for randomized control trials. But because for those trials that we're evaluating, the social demographic, for the age and gender-wise, they're pretty much even distributed. So I wouldn't say they are, confound too much. But if we, assess something, not just randomized control trial, but other study designs, it's really a good idea to control some, major social demographic factors into it. Yeah.
It's going to be interesting to see how different journals accept when you mention the limitation, how you describe that. Just look at the p-value for the mean difference in milligram per deciliter over there. It's 0.000000. When you go to the HG, see how conservative it is? It brings back at least 4 or 3 zeros because it assumes that these populations are very different with age, with gender, with the main characteristics that affect the outcome. And interventions are very different, the settings are different, the timing period, all the influence. So it's a conservative approach. That's why the random effect is a conservative. So it increase your variances tremendously. So if I could put the real value there, it would be a 0.000001. It went to 0.003. See that? It's a huge compensation. So if it does adjust for all the age in the right way, you have to do it individually to see it. But it assumed by the theory that how much distribution can be so different in studies between people already in the same age group, between 46 and 80. So they're all older than 46. So how much difference in age you can have? The HG kind of indirectly adjusts by the random effect application for the difference in between the control.
It's so nice to talk to statisticians. Potentially probably have other ways to do meta-analysis. It should be probably a better way to look at it. So this is result for triglycerides. And the use of HIT was also significant associated with the reduction in triglycerides, and we reduced by 18.6 milligram per deciliter. And our HG also indicated a median effect size. So we didn't find a significant result for weight. And you can see that almost all the individual effects sit on the null value. I look back to the literature and try to find some explanations. So for weight loss trials for patients with diabetes, so it's really often to see a weight plateau starting from 4 to 6 months. And this is potentially due to the decreased energy expenditure and increased calorie retention, and also the psychological fatigue. And also there are potential some medication effects into it. So I came across a study talking about the side effects on the glucose lowering medications. It potentially increased patient weight. So it's really unfortunate that we cannot single out the effects from medication here, but this potentially provide an explanation for the non-results we are seeing here. So we have a concern that the measured effects of HIT from those trials are mixed products from standard care and treatments. So to address this concern, we identified the trials that comparing a combined HIT and standard care interventions versus a standard care alone controls. So in a way, we kind of want to see the independent effects from the HIT. It's not just a mixed products from both. So we did this subset analysis, and we found that the result is very similar to the result we found in the overall analysis. And actually, for the reduction in blood pressure and LDL, the differences in means was even slightly greater. But really want to emphasize here is that, so the standard care components in the interventions may not be completely identical with the standard care components in the controls.
We also lost some of the significance for the HDL and triglyceride.
Yes.
They're very significant before, as you remember. Now with this very specific analysis, really trying to separate out the true effect of HIT, we lost some of the power we had for HDL and triglyceride, so we lost it. But for SPP, DPP, and HDL, I'm sorry, in LDL, it's identical, even though it's stronger. So this more specific analysis does the job of showing. So you can see the comparison. HDL before was 0.001 with the hedge, and then we go up. And that's not really significant.
But I think for the patients who were recruited to those trials, so they had to have elevated blood glucose or elevated blood pressure or cholesterol. So this is a criteria to be included. So if they have this, risk profile, they are very likely to already receiving some treatments or standard care. So it is kind of reasonable to assume that there are some effects from the standard care. It's just that because the papers did not present their protocols or clearly what specific components in their study. So we really couldn't single out the effect from the standard care or medication, but we tried our best to provide a subset analysis and trying to see, within those studies that who reported clearly on this, standard care and in the interventions versus controls, then what the outcome would look like. And actually doesn't differ much.
So did you look at the base, did you calculate what was the baseline average systolic blood pressure before the intervention of all the participants? What was the baseline? So for your systolic blood pressure,
yeah.
Did you look at what was the baseline systolic blood pressure of all the participants that were included in the meta-analysis?
Yeah, this part probably, I did it for the H1B for that baseline, but for the 6 outcomes for CVD, I probably didn't include this, but that's that should be included in the
supplemental.
Oh, okay.
For every study has their blood pressure, baseline, follow-up. We have all everything.
Oh.
So if you read the first paper, all these numbers are there. But we didn't do a breakdown again based on those smaller number of studies.
Okay.
We could have.
Okay.
The editor, it's funny, the editors on the first journal kind of suggested we put the supplement on the first one, but this one, maybe because we referred to the first one. Because it's pointing to, but the original one has a major supplemental table that it doesn't fit any journal, so it has to be a supplement on the web or something because it's very large, every detail.
Yeah.
each one of the studies.
Yes, I believe we have that set of information in our the spreadsheet, but didn't report it in the paper. But that's a good point. So in discussion, so we want to see the effect size that's produced by the HIT. How comparable is HIT to other effective lifestyle interventions? So actually, we found that HIT appeared to achieve the equivalent or even slightly greater effect as some lifestyle interventions that designed for CVD risk management. So you see the sodium restriction was associated with reduction in SBP around 5 milligrams of mercury and DBP by 2 to 3 units. And this is essentially the same that we identified from the HIT trials. And this the increase of fiber consumption leads to only 2.2 milligram per deciliter in LDL, and increase in NAD consumption leads to a 10 milligram per deciliter reduction in LDL. But HIT was associated with 8. So yeah, I think it's comparable to dietary interventions. The third one is comparison for the good cholesterol, HDL. And HIT was associated with a 4 milligram per deciliter. And you can see that aerobic active training and smoking was almost associated with the same amount of improvement. So like I just mentioned that we don't know the medication administration, this set of information in the papers because they didn't report it in their publications. So for this reason, we couldn't really separate the effects of the HIT from the possible medication administration. And we did not report smoking. And smoking is another CVD risk factors. And that actually, I think in the guidelines, is one of the 7, right? Mm-hmm. So, and I think for those HIT interventions, smoking is usually not measured. So we couldn't provide analysis on that. And another limitation, we did not review studies that published in non-English language.
So what that means is that there's not an enormous possibility, a small possibility that by chance you have an HIT group non-smoker more predominantly in the smoker the other group. So the difference could be explained by smoking. We acknowledge that in a big end of presentation, but it's very unlikely by chance we have all the smokers in the other group. Because those trials, they are randomized trials. All these are randomized trials. So by randomization into groups, you should expect intervention control groups because they are good for the demographics. If you look at those RCTs that we reviewed, all 27, they're perfect comparison in all the demographics. So you know that smoking is highly correlated with your main demographics, with your social background and everything. So we can't say it. It's a smoking adjustment would not change that. We cannot say because we don't have the way to do a number. But it's unlikely that this type of bias or any other bias associated with confounding specifically or selection bias would affect a randomized control trial like those.
So did you limit to adults more than 18 years of age? Did you limit it to adults more than 18 years of age, or did you look at everything, even like adolescents and youth?
I think there's only adults.
It's adults.
Yes,
or the-
yes.
Actually,
These
the
are
age
some
groups you
adults.
presented early on, you saw it on the first slide maybe.
Yeah.
Between 40 something and 70 something.
So they said when you did the search, during the search, did you limit it to like more
No.
than 18 years?
No, we did.
Oh, okay.
We limit to adults, not to adults from 46. This is what we end up with,
Okay.
given the quality of the trials, because we have a lot of parameters in those, 3,000 papers, and we start breaking down which are true randomized controlled trials, have all the information, have the baseline needs for the variables we want, have the follow-up measure, have breakdown for demographics, everything. So once you put it all together, we end up to 27. And the age group of the patients between, I think it's 45, 46 to 78 or something. But we did not restrict to just this old age group. Okay?
Yeah, I think when we searched the literature, the age was not a criteria, not one of the criteria, but we did just specifically look into adults with diabetes because also for the CVD risk management, you would only assume that it's relevant to older people. So yes, I think yes, this is we should maybe highlight this for adult population. So in conclusion, so the combined HIT, so the wording Dr. Simoes revised it, and the combined HIT and the standard care of type 2 diabetes was associated with a reduction of main risk factors for CVD, especially for blood pressure and cholesterol management. And this finding suggests that this HIT should be used in combination with standard type 2 diabetes treatments for the greatest impact on, type 2 diabetes outcomes and related outcomes. And this is also, this two meta-analysis, good findings also provide a strong rationale to look the, broad applicability of HIT beyond the research setting, because this is randomized control trial is well controlled. So we want to see that, how HIT may play a role in other settings and populations. So this is probably the start of a big project. We really want to just carry this on and potentially apply for a bigger scope of the study proposal. So the immediate next step, so we were thinking to further review some of the facilitators and barriers of implementing HIT to other settings and population. We propose to use a REAM framework to do this further systematic review, and we hope to borrow that findings in combination with our two meta-analysis to design an effective trials, a bigger scale trial. We probably can try a pilot run on that. So, but that's going to be a collective effort, not just between Dr. Simoes and me and other co-authors, but also from Dr. Kim, and who has knowledge in the, and Chin has knowledge on the app designs, and so for clinicians like now statistician like you guys, so that we hope to build our own trials and test its effectiveness.
Yeah, I would add to this from Dr. Kim and Dr. Yin, they found to be doctor, right? They found that apps are not that hot.
Yeah.
When you compare that to what's expected based on the AED, recommendations for patient self-care management.
Yeah.
So that makes us think, okay, we find an effective HIT. That's not all HIT, and this is a global, and we don't know which apps are actually working. And we have a sub-analysis that we should have presented here. We've done for the other one, for the diabetes A1C, which you look at just the subgrouping of HIT, text message versus apps on a mobile versus telemedicine versus this. And the apps actually, it looks like apps and mobile had the greatest impact on the A1C.
Yes.
But again, when you look at the two research papers that Dr. Kim produced with Dr. Ye, it casts out whether you can just throw a wide net. You have to be careful when you say that. So the next step here is say, okay, how does HIT is actually influencing diabetes outcomes, including cardiovascular outcome on the diabetic patient? So what are the enhancers and barriers for the adoption of what HIT and who is using them? Is the large population being covered? So we're going after more like a detective work now to do implementation research to see what is implementable. And maybe what we want to find is something that's already implemented, disseminated. But we may not find. If we don't, it gives a lot of justification to do a better trial, an effectiveness trial, as opposed to an efficacy trial. These randomized control trials, if you look at them, they're really more like efficacy trials.
Yeah, they are.
They're not real world, large population, and long period of time. Some of them are 6 weeks, 8 weeks, 4 months. What if we do it for a whole year in a large clinic, primary care population? So that's our goal. But then we need to go to the next phase of this detective work and dissemination implementation. And I invited Dr. Glasgow, a guy who invented REAM, to collaborate, and he's open to work with me and Dr. Yoshida and Dr. Ross Brownson, who wrote the ultimate book in implementation, dissemination, and prevention. So both of them will be our co-collaborators, the guys who invented the field. So we hope to get somewhere with that. But I think the next step is going to be meeting with Dr. Kim and Dr. DK and to learn more about the studies they did and see where we can go from there. Maybe, just maybe, some of those apps they review is in the review that we did. It's one or two of those that we reviewed, those 27 for CVD, 30-something for diabetes A1C.
Yeah.
If it is, we have a target to go after those and understand how they've been utilized post-study. Have they been implemented in a system, health system, on a clinic that they continue to use, so we can learn. So we can do our implementation dissemination trial right there.
Yeah.
And then from there, go beyond and try to do an effectiveness trial.
Yeah. So I think AHRQ has published a review on apps, diabetes apps. I think I came across it like 2 months back, but they actually came up, there were 5 apps that actually followed all the guidelines. And so they have listed them, like all the others, like there are like tons of apps, but in those, I think they listed 5 apps that actually follow the ADA guidelines.
ADA, but interesting because the ADE, which is a different organization, when you look at that guideline, that's Dr. Kim's work. I would say most of the apps, they fell short. They're actually pretty poor. So I don't know how they're getting the effect. Maybe you don't need to really hit every button of the guideline and have an impact. It's possible, right? So we need to investigate that. That's the next step in the research.
So,
I have a question.
sure.
Could you go back to the slide for the effect of systolic blood pressure?
This one, right?
Yeah, you see that one of these publications, the fact is very hard there. Did you check for, it might be an indication of the publication bias?
The publication
So
bias.
did you check
Actually, publication bias, let me show you our bias assessments results. So I included in the last few slides that I didn't print it out because I think I thought I didn't have enough, I don't have enough time. So for publication bias, so here is the funnel plot. So it's just, a mild asymmetry, I would say. And also I did this test, the fail, safe, and additional size. So you would say that for the SVP, you would need more than 200 studies to be included in your analysis to see the loss of your significance. And the treatment trial results, this imputed results is very similar to our original results. So I wouldn't just worry about the publication bias. But one thing that I discussed in my discussion is we see a kind of a very big heterogeneity for SVP. So I provide some explanation to that since the reviewer accepted. So I said that we have the studies across all over the world. So this is a variety. This is sort of the variance in it, and also for the intervention that we evaluated, they can have a very simple delivery. For example, just a phone call to a very complex interventions. For example, they have the monitoring and we have the communication every day. So this different kind of intervention components potentially is another sort of variance. So that's potentially explain the heterogeneity. But for publication bias, I think this study is good. Yeah, thank you.
Study quality assessment or study quality assessment?
Yes, so, so it's right here. So most of the for most of the criteria, I think we're good, except this allocation fulfillment. No, it's actually this blinding of participants and personnel. So blinding, so our result outcome is objectively measured, blood pressure, cholesterol. So blinding or not, it really doesn't matter. So if you say some mental health skill or measurement, that's probably a problem. So
you're talking about allocation concealment.
No, I'm talking about blinding of participants. For this one, unclear risk because we don't report this in your paper. So we wouldn't know is this risky or not. But for this blinding of participants, so they say they're not blinding their personnel. So we can, can read it as a high risk But, you know, just like I said, so it's objectively measured outcome, so it should be fun. So I think that's why they didn't even blind their personnel participants.
Yeah, blinding is very important. But in a randomized control trial, we have measurement like A1C or blood pressure. It's very hard to argue that blinding could cause the change in the number you see, unless a person falsifies the data, okay, which is a possibility. But since they're all scientific studies published in peer-reviewed journal as a randomized control trial, you know, you have to consider. But let's say you have a different type of measurement. And also, it's not just the objective measure. Objective measure, they have a lot of error in measurement that make a difference. You know, blood pressure, it's the amount of error in blood pressure, it's huge from the patient perspective. If you ask them, are you a person who ever been told you have high blood pressure? Absolute majority of people had once said that your blood pressure is up 60 and it's high. They say, yeah, I have blood pressure. So they have no understanding truly what high blood pressure is, the patient. But when you do this from perspective of scientists, with nurses and people doing that, when they measure you, they're using standard, then all of them describe their method on standard, meaning you take the blood pressure sitting, laying down, after you relax a little bit in the doctor's office, not immediately. So we have techniques. So when you do this, the variation in blood pressure, for example, it's not so high. But things like lipids and stuff, that's standard. You gotta have a bad lab really to get everything wrong. You know, especially triglycerides. These are diabetic patients, they have high triglycerides. You know? So bottom line is, yes, those things are creeping in, especially the blinding. And concealment is part of the blinding. I mean, concealing, it's one form of, you know, not allowing the scientists to know where it's being allocated.
We use a criteria from this Cochrane collaboration risk applies to. So I think this is the standard too for folks to do the meta-analysis.
So these are the only two problems here. But again, the standard measures are being used in randomized clinical trials. So we see how important is the blinding here and allocation considered. You start questioning when you look at through the eyes of the study investigator yourself. Okay, so, but it's a concern in study. So we put all of that in the paper. So, and that's what's good about science. There's no perfect science as long as you accept that you have problems. So we accept that. So you can see the paper with all of that, including all these graphs and everything. So a person has to make a judgment. We want to believe the size of the significance for the hedge are so huge. Talk about 0.03 of p-value for blood pressure, 0.001 for something. If you just look at difference in means, it's extremely significant. That doesn't mean anything. I want to look at the standardized with a random effect, assuming that all these characteristics of the population being studied, the designs are slightly different, and therefore they should expect differences. So by treating a random effect, you explode the variance estimated for any one of those differences. So you're being very conservative. So that kind of take care of most of, in my opinion, most of the bias, but not everything. So that's why information like that is critical. Start thinking, okay, how blinding could affect measure of triglyceride. In my opinion, as a physician scientist, zero effect. But possibly blood pressure, because the person has to write, not a standard clinical laboratory, from apparatus that calculate the triglyceride level. This is a person who actually measured. They can write down a different name. But what's the incentive, for a nurse or a technician doing this? So you start wondering if this is really a bias. But it's possible, and it's all there in the paper. People can judge for themselves. It's worse when you publish your numbers and you don't publish any of the limitations we publish. The biggest limitation to me is actually the medication issue. They have given some information, but you don't know exactly what is the medication. Even the dosage of the medication may make a difference for some group of patients and the other, even though they standard treatment for cardiovascular for diabetes. But the dosage, the manner in which the patient gets compliant with that dosage could affect. But what are the chances that this changes will be totally non-random, and only the treatment group will get the best people or more? It's hard to believe in that. you don't have any evidence in that field. But you write it down and you let people make the judgment. I want to believe there is some decent effect of HIT. What we found is the average, but I don't disagree if people don't want to believe based on what you produce in the paper. You show those two bias, they're concealment and blinding, and then the fact that we have the drugs not completely being disentangled, their effect from the HIT. And interventional control, you don't know exactly which drug the intervention is taking, which drug the control group is taking for every study. So I only select maybe 2 or 3, we have all the information to do it, even a sub analysis. But it would be a lot of work for maybe nothing. So all those bias we could study.
Yeah. I'm very excited about this project. So I'm trained like a chronic disease epidemiologist, but having a chance to participate in a study like this, and this is really, to me, it's innovative approach to address the chronic disease management. So yeah, I hope to do well, of course, with great support from a variety of experts here. So yeah, we can grow this project into something bigger. Yeah, thanks everyone. Have any questions?